There is no history of headache, seizure-like activity, and vomiting. Now coming to past surgical slash treatment history, patient is a follow-up case of pituitary macroadenoma. Post-op transperineal excision of pituitary tumor was done on 24th February. He had blurring of vision for 4 months with headache and nausea. Nausea was progressive in nature and not relieved on medications, and that is why he was diagnosed with pituitary macroadenoma, and then excision was done. Past medical history, patient is a known case of type 2 DM, controlled on OADs, tab vildagliptin and metformin 50,000 BD and voglibose 0.3 BD. And he is also a known case of glaucoma on regular treatment.
What was the treatment, other medications which he was using? Because these medications have an impact on hypertension.
Right, so patient was probably inhibitor, right? So they would assume impact on hypertension, but with time metformin and nothing to balance, and he was not vulnerable, so nothing to be
Diuretics at any point in time? Diuretics?
No, he was not a
After surgery, what was the treatment?
After surgery,
he was given some steroids. It was given to surgery, not a post-op. Patient was given steroids for 2 to 3 days, and that was weaned off, and he was on this medication only. There was no specific medicine that patient was on. The patient was absolutely fine because he had got symptoms. After surgery, the patient became very well.
Preoperatively, you might be given mannitol for the raised ICP.
It was during possibly because
Maybe during
he had not seen the
surgery.
reports and
Does the mannitol effect last for 1 week?
but the patient post-op was unable to But patient post-op was quite unable to most of the time.
So he was operated on the 24th
Yeah.
and was discharged on
It's not after 3 or 4 days, more discharge.
3 to 4 days.
Stable, yeah.
So within 3 days of discharge, he came back
And
and
he
he
came
was
back to OPD, follow-up, right? And then I will also see my OPD. Let us see what is
But he
happening.
was operating in some other institution.
One of this is true.
Okay.
Okay.
For the
Patient of quite deeply got restless, so I thought there's some issues. I thought that patient might be going hyperpatriotism, pan-patriotism.
Exactly.
Some
Okay. Sure.
We just admitted the patient and
Very good.
now coming to the general physical examination, the patient was conscious but restless, and he was oriented to time, place, and person. His blood sugar was found to be 113. SpO2 was 98 on room air. Pulse 80 per minute. Respiratory rate 20 per minute. Temperature was 98.3. Blood pressure 140 by 80 mmHg. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. Now coming to the physical examination, in the GIT the tongue was dry, dehydrated, per abdomen was soft and non-tender. CVS there was S1 S2 were heard. In respiratory system bilateral air entry was present. CNS patient was conscious and oriented to time, place and person. Pupils were bilateral, equally reacting 3 mm and moving, and he was moving all 4 limbs. Power was 5 by 5 in both upper and lower limbs. Reflexes were present in both ankle and knee.
normal bilateral air entry was GMB,
Okay. Too much abbreviation.
And plantar is reflex.
Where could I say
but then we could not find any neurological deficiency in this person.
के फैट में हमारे एग्जामिनर जो आया था उसने उनको कैंडिडेट से बार यही कहा कि ना ये एब्रीविएशन यूज करो
Exactly.
too many abbreviations.
Now coming to the investigations. On investigation, sodium was found to be 114 milliequivalent per liter. Serum osmolality was found to be 243 milliosmol per liter. So he was having true hyponatremia. Then sodium spot urine was found to be 119 milliosmol per liter, and urine osmolality 512 milliosmol per liter.
So what are the normal values of sodium? Sodium serum osmolality, and normal less than 120 is the critical values.
Sir, 135 to 145.
वो तो normal है. 120 below 120 is a critical situation, isn't it? And serum osmolality, what is the normal?
So 280 to 295.
2, yeah, because the or sodium, अच्छा ठीक है.
This cortisol item, is this in nanomole per liter or what? You've not written the
Nanomole.
nanomole.
Yeah, so the serum osmolality is on the lower side. It's
Yes,
so
yes.
that is probably true.
Right. So I think, so the size right at, as a beginner, resident should know the normal value.
Yes.
So if we define hyponatremia, right, so it is normal state is more than 135. 135 से ऊपर हो चाहिए normal. And from normal, अगर suppose mild है, moderate or severe. So it is mild, it is less than 135, say 125 to 135. ठीक है. Moderate जो है 125 to 115, but severe as I said, less than 150 it is severe.
Less than 120 is critical.
This is
Severe.
possibly 114 is severe.
Exactly, yes. 120 के बाद
The patient is showing symptoms also. Patient is
Exactly.
Yeah,
So it is
patient can go
Yes,
into
we
coma,
are-
acute
convulsions and arrhythmias. All the
Yes.
situations can happen.
But a severe acute happening because the acute is only about 1 day. So we define acute and chronic. Acute is less than 24 hours and chronic is more than 40 hours.
Yeah.
So this
And
is
in
all.
chronic patient will have less symptoms.
Yeah.
But in
Exactly.
acute, sudden acute.
Because adaptation would be there.
Very severe.
Adaptation would be there after 40 hours. There will be some adaptation.
Yes, yes.
But in acute, the patient would not get chance of adaptation. The patient would go recover from very fast. That's why
right.
it's called a medical emergency.
Exactly.
This is, I think, is a medical emergency. The patient comes.
Yes, absolutely.
So we did admit the patients in this MICU, neurological ICU, and COVID diagnosis was made by neurologist was DI, diabetes insipidus. But this is not diabetes, because diabetes insipidus.
What could be the
No,
cause
no,
of
that
this
is,
surgery?
that
After
the
the
urine
surgery.
osmolality will be less.
Yes,
That is the thing.
They make a product of diabetes.
Yes.
Diabetes insipidus is very common after this surgery.
Yes, yes. And then the volume of the urine which will be passed will be in liters.
Liters.
6 liters, 10 liters, like that. Yeah.
Polyuria.
Polyuria.
And there would be hypernatremia.
Ah.
Hey, but
Yes.
see, the classic question is, after 7 days of surgery, what could be the cause of acute, hyponatremia in this patient? Did he eat after discharge? Was he eating something or not? उसकी food habits और intake कितना था after the discharge?
Patient was absolutely normal. Patient was ठीक था, बिल्कुल
She
ठीक
was
था.
absolutely okay,
Only
eating
one
well,
day.
no problem.
Okay.
एक दिन में ही सब कुछ हो गया.
And also he was not vomiting. Like he said.
Ah, yeah, that's what-
Which means his GI was okay.
So this is acute severe hypernatremia because serum fluid is less. Normal
Exactly.
serum fluid is 280 around, 280 to 290 I would say. Spot use the sodium spot urine is 109. Normal is should be less than 20 if you say the normal patient is more than less than 20
Yes. That is only in presence of hyponatremia.
hypernatremia.
If not in presence of hyponatremia, there is no defined value.
No defined value.
Yeah.
Very true. But if you define hypernatremia algorithm, it is
Yeah,
like
then it is less than
20.
20.
It is less than 20.
It is less, renal saving, if the kidney is
So your diagnosis, different diagnosis would contain, shrunken. Right? If you say that, okay, there is incidences where in cases where sodium is more than 20 or less than 20.
मैं जाके आया हूँ अभी जाके आया हूँ बोल के आया हूँ हो जाएगा
Defined.
तब तो फिर हाँ रिपोर्ट आ गई पता चलेगा
So I think what would suggest what would the patient be having?
adrenal insufficiency.
First diagnosis will be
Also we would like to see the electrolytes potassium also.
This will fine.
Potassium was okay.
And Arena also.
Bill, just
Here post is a post-pituitary adenoma.
Potassium 4.5, calcium is okay, urea creatinine was normal, and thyroid functions are normal, and it is a random cortisol.
Actually, that is very less, 70 nanomoles.
70. So I think the normal value is around 20 to 10 or something. Range of these cortisol.
6 to 20%.
6 to. I see range of this.
तो ये तो ज्यादा है.
नहीं, that's what I'm asking. Is it in nanomole or is it in microgram?
Because normal is
No, sir. If it is in so 6 to 22 which you're saying, that is microgram per deciliter. That is in microgram. But if the values are nanomole per liter, then it has to be more than 270 to 550.
Yeah.
ये microgram.
So it is high. It is high. It is high.
Yes, sir.
So if it is high, then hypocortisolism will also.
No, that's why I wanted to know what are the
Exactly.
70 is little less. Because what happened, the patient was given steroids in the pregnancy.
Oh.
And the patient got okay, patient is hypoadenoma, just give us fallen. So I just repeated a little later, just take the cortisol before injection.
Yes.
So in the ER, what they did, they just, they gave me 100%, probably this 100% bar है sir.
So that's why it must be microgram per deciliter. That's why the units are very.
So that would be microgram per liter, possibly.
6 to 22 was the normal range, so ये ज़्यादा ही था, 17, 17.
But that 100% is ruled out.
Matlab, if you're given short of a hydrocortisone, then this value has no relevance. Matlab, I cannot translate out.
Plus hypercortisol was more of the cortisol, which was less of potassium and high of sodium, isn't it? Because when you have Cushing syndrome, you have hypertension because there's more of sodium in the body and less of potassium. Like whenever we are treating our bronchial asthma patients and with steroids and with nebulization, all their potassium goes down to 2.5, isn't it? So I'm surprised that with high cortisol, how much that
This
is
is after an IV shot. This has
So you are saying
this particular value.
short of steroid, this not rule out personal
This particular value has to be not taken
okay,
into
yeah,
consideration.
yeah.
So
This is
possibly if you
out.
if you suspect that you can repeat the sentence
Okay.
After 12 hours.
Yeah.
fasting.
Yes. Yes.
Oil use
Oil
for
use
lot
Sorry,
of
the
stimulation test.
Serum
No,
cortisol
sir,
needs
in
to
this
be
situation, simulation test
taken
will not be
with
required.
always. So serum cortisol, the timing of the sampling has to be very
8 and 3.
with or without the falling. If you're taking the falling, it makes sense.
No, sir. Actually, in emergency, the timings have no value.
Yeah.
In any acute stressful condition, if you
Point is
do
that you cannot pay much value to such a level in an emergency.
no, sir. So if I have a very similar patient, okay, just for an introduction, I'm an endocrinologist, so I can speak with some confidence on this.
Sure.
So if a patient like this presents to me in emergency, and if I take a sample without an F-colon shot, and if it is less than 10, then for all practical purposes, I'm gonna label the person as having an AI, adrenal insufficiency secondary to surgery. So a less value in an emergency is fine. A more value, if it is more than 18, then it rules out adrenal insufficiency for all practical purposes. If it is less than 7, it proves adrenal insufficiency. Between 7 to 18, I am nowhere. I'm gonna assume that the patient might have adrenal insufficiency. I'm gonna treat the patient as an acute emergency, give F-colon, then evaluate the patient maybe 6 weeks later.
So my point was hypercortisolism cannot be
Yes. Absolutely.
made a diagnosis based on
Yes.
the
No.
cannot be certain.
Yes, sir. Absolutely right.
This is what I
Yes.
said.
Next.
These were the other investigations, all were within normal limits only. So the provisional diagnosis,
So the picture of this hypernatremia, we have ruled out this hypercortisolism. Low, the high use will deliver osmolality, low serum osmolality, serum sodium is less than 14. So the diagnosis would come to mind is for this syndrome of pituitary dysfunction, and it is very common after this macrodome surgery. This is the evidence says. But the issue was that the patient was already dehydrated. The patient was SIDS, the volume is low volume. The patient is not dehydrated. We just thought it is possibly could be having this CSWS, which is cerebral short resting syndrome. And with other DD that came into our mind. We have ruled out thyroid hypothyroidism. We ruled out AI.
We not ruled out.
Not ruled out. Not ruled out. The thing that comes in mind is the patient cleaner status. Patient is probably dehydrated, right? So, but in SIDS, patient is really dehydrated. It is low volume. In fact, there is a volume expansion initially. If you look at the patient SIDS, we do get a lot of patient SIDS. So there is initial volume expansion, but the patient is usually low volume. So possibly this is hypovolemic hypernatremia.
Any drug history?
No,
No drug history.
This is possibly we are going on everything. Hypovolemic hypernatremia, symptomatic, severe acute hypernatremia. This is what I call differential. These two different diagnoses will come to our mind, SIDS, and this is cerebral short resting syndrome. Cerebral short resting syndrome is very rare, sir. It's not very common, right? But other things that will, so we just work on that, and then we treated the patient. So the patient was dehydrated. We started with iron cyanide. Right? We didn't give 3% in this case. Our patient seems to be in this hypovolemic. We started with, and treatment of SIDS this is different. So in SIDS you have to have fluid restriction, and in this cerebral short resting syndrome you have to be fluids. So the diagnosis should be very accurate because अगर आप उल्टा करोगे तो patient would be patient would deteriorate. अगर SIDS में fluid दे दोगे patient would deteriorate. उसका hypertension का बढ़ जाएगा फिर. Fluids.
so sodium was corrected gradually with maximum correction per day aimed at 8 milliequivalent per liters to avoid cerebral pontine melanosis. Gradually, patient clinically improved with improvement in urine output and correction of sodium levels. Patient was discharged on 7th March with sodium of 138 milliequivalent per liter.
So then 40 after 40 hours, patient sodium gradually goes down.
That's what I
Patient sodium was relieved.
48 hours.
After 40 hours, patient relieved, and the patient was discharged on this 130 milliequivalent, and now patient, there is no issue. Patient is free.
Why you say 8 milligram per day? When it is allowed till 12 to 12 milligram per day?
8 to 12.
So maximum 8 to 12.
Not 8.
Dr. Pankaj, how you assess that the patient was hypovolemic?
Clinically.
Clinically, some parameters?
So dehydration came whether patient dry or dry. So there, so yeah,
Why dehydration? Because was there any cause?
there might be
Blood pressure was normal, he didn't have
there
tachycardia.
must be some issue because this is what in the literature says that it is very difficult at times to diagnose this case as a dehydration. Okay, but sometimes on because you have to have that feed this 10 log, CP line, the pump pressure at least. What is the volume status? Right? IBC, you will to be the patient was so critical at that point of time, so we didn't do anything.
Because normally, we
Coastal
treat
hypertension,
patients,
oliguria.
especially with severe hyponatremia,
Other thing is
3% sodium chloride. And we obviously aim to increase the sodium by not more than 8 to 12. But actually, we 8 to 10 or something like that. And by
12 to 15.
whatever amount of so 3% sodium chloride, we manage to do this with Propi. But managing with sodium chloride alone,
Right. I think
is
it's
what are the fluids are we talking about here?
so like
Normal saline is not 1.9. Because the cause of replacement for hypotension.
No. See, hyponatremia, you have to define whether it is hypovolemic, hypervolemic, or euvolemic. Without that, you are meaningless. If your person is repeated vomiting, diarrhea, saline is the only thing that you give, nothing else. And I have seen people giving 3% saline, giving lot of salt, and you.
Lot of salt
That's
is
wrong.
also.
That's wrong.
Lot of salt is.
There is nothing wrong in anything. You have to understand the concept that saline is
In the presence
your
of
saline is
hypovolemia,
normal saline. It is
NS
0.9.
is the drug in fluid of choice.
So वैसे भी आपके पास basic understanding is 3% what is 3% saline. You are giving 3 gram in 100 ml. And what is your normal saline? So you are giving 4.5 gram. You are giving 4.5 gram of salt. It is only difference of what, how much volume you are loading the patient with. It's just the mindset of people that 3% saline is a big thing. It's 4. If you infuse 2 bags of normal saline, you are giving 9 gram of salt. And you are saying 3% saline you want to infuse. You have to actually understand that your patient is hypovolemic, hypervolemic, or euvolemic.
So I think
Then you decide your
I think second case would be Manisha. So we just actually kept the case because very she came into on our third, so we were not trying to review everything. But whatsoever I just presented, so in the view only discussion part. Right? We discuss how you
So
are
for
going
practical aspects of that, I would like to find whenever correcting saline, use one strategy in one go. Use one strategy at one time. If you are not able to assess whether the patient is euvolemic, hypervolemic, or few histories are very clear. If somebody is vomiting, is having loose motion, then you just use saline. Else your strategy should be you will be assessing every 6 hours. Also your basic strategy.
This patient did not have
We did not have any cause for hypovolemia.
All of hypovolemia can be sir, as much as somebody has not taken an intake.
Sir, we discussed it.
The history was that he was taking normal food till 1 day prior in the previous effect. So,
Sir, we will discuss. Okay, we will discuss. Let me finish out. So this is just a very important slide that Dr. Paras is mentioning about. We have taken it how to approach a case of hypernatremia. Right?
Yes.
This is very important. Just know the patient is alcoholism. You have to measure the serum osmolality. And one of the questions that is asked people during exams, so what is the main crux of measuring hypernatremia? It is a volume status. It is simply the volume status. You have to assess the volume of the patient, right? So you have to measure serum volume. Then normally we all know that it is 280 round. So you have to exclude pseudohypernatremia, right? Because the serum sodium is normal. Because in this case, there is low serum osmolality. So if the serum osmolality normal patient is coming with hypernatremia, you have to rule out pseudohypernatremia. Pseudohypernatremia can be there with hyperthyroidism, hyperglycemia, other causes, right? So then, if the serum osmolality is elevated, then the patient is at hypertonia, right? So there is, the cause would be hypoglycemia and measured effective osmosis, like glycemethol is used to give in post surgery. And the serum less than 280, it is hypotonic hyponatremia. This is what the evidence goes on. Right? If there is hypotonic hyponatremia, this is the case, then you have to define that the patient is hypovolemic, hypervolemic or euvolemic. You have to assess the clinically, right? If the patient is hypovolemic, right, it means that total body water is less, total body sodium is also less, and effective RTA blood volume is low, and you have to look for urine osmosis. Urine osmosis is more than 450, then you have to look for serum spot urine sodium. So the urine sodium is less than 20, the cause will be external losses, parasite, vomiting, diarrhea, thirst, like burns, peritonitis, bowel obstruction, or trauma or fatigue. If the urine osmolality is more than 20, okay, then cause would be urine losses, patient would be diuretics, mineral cortical deficiency, salt losing nephritis, cerebral salt wasting syndrome, right, and metabolic necrosis. So this is the causes of hypovolemic. So our patient would be fitting into this hypovolemic hyponatremia, where the serum sodium osmolality is less, serum sodium is more than 20, it is almost 119, serum sodium is 114, and urine osmolality is more, right? So it is fitting into this hypovolemic, and this cerebral salt wasting syndrome is mentioned there. Okay, so treatment we all know we have to treat the cause. Then patient hypervolemic, this will be see whether urine osmosis is more than 100, serum sodium less than 20, more than 20. If it is less than 20, causes are CHF, reproduction of the fluid overload status. The urine sodium is more than 20, causes could be acute or chronic renal failure. Another one is euvolemic hypotonic hyponatremia, and sometimes this is the most common presentation we used to see. And you have to look for urine osmolality is more than 100, and urine sodium more than 20. The causes are TSH, hypothyroidism, glucose deficiency, and SIDS. These three are the common causes. Urine sodium less than 20, the cause would be primary polydyspnea, low solute intake, right? And accordingly you have to treat. So this is the basic algorithm of patient when you define. So our patient probably lie on this right left half when there is hypovolemic hyponatremia, right? So, and the causes are mentioned here, cerebral salt wasting syndrome, one of the DD of particular patients, right? So this is what. This is a treatment, this is for the how you treat. It is less than 40 hours, more than 40 hours, acute or chronic. And 3% line, usually that 3% line very frequently in patient. And now they will go to the chain. Now sometimes patient that go infusion dose, second day, now it's not there. The patient is acute symptomatic, you give boluses. You give 100 ml bolus over 5 to 7 minutes. Just wait for 5 minutes, look the patient status. The patient status remains unchanged, then you can give another bolus, right? Of 100%, 100 ml, 3% line. This is the guideline that we changed recently. Now we used to give 6 to 8 milligrams per hour. I think now the boluses are, you can give boluses also. Only definitely we need to a little worrisome because the patient would develop this online boluses.
Even if we are giving boluses, the correction should not be more than
8 to 12 liquid
More than 8
in first 24 hours and up to 18 milligrams in next 40 hours. This is the what the guidelines say. So
only for acute
diabetes. So this is the complication of P2P surgery, and you can see the hypertension is the most common presentation. I was actually, when I saw the literature, I thought that just ATI or hypocortisol is probably the most common after surgery. But you can see this is almost almost 10% patient would present with hypertension. This is the hypopituitarism, then CSF bleeds, patient may present with gastric insipidus, transient or permanent, and other claimants as these cases are there, right? So if you look at this case, that patient, what are main causes of hyponatremia after acute surgery, and Dr. Pankaj said that why the patient developed hyponatremia, right? So I would go to answer that. So this is the common causes of this hyponatremia after acute surgery. First is SIDA, no issues about it. First is SIDA. Second is cerebral salt wasting syndrome. Other is AI or hypothyroidism. Third is overload of hypersolution. That the patient get hypersolutions. The patient go into hypovolemia, this hyponatremia, and high dose of desmopressin acetate in the stage of diabetes insipidus. Sometimes patient develop diabetes insipidus. It is also sometimes common after acute surgery. Patient gives the high dose desmopressin. The patient will develop hyponatremia case. This is not in our case actually. So this particular SIDA you all know. We have read in the literature that after acute surgery, there is increased ADH in the setting in the background of normal osmolality, normal blood volume. There will be water retention, expansion of cerebral volume. There is increased natriuresis. The GFR will become increased, and there is less sodium absorption. So the crux of this slide is the patient develop hypernatremia, patient develop hypernatriuresis plus normal blood volume. This is important. In SIDA, the patient becomes euvolemic despite of hypernatremia. So there is basically not a problem of sodium, it is a problem of water. So this is what we call a dilution laboratory. Sometimes we say that. Therefore, fluid restriction is the main stay in the treatment of SIDH. Right. So this is the diagnostic criteria of SIDH. Main criteria, the second major criteria, main criteria. Serum sodium less than 135, they decrease ECF fluid osmolality less than 280, elevated urine sodium more than 20, lack of signs of hypovolemia or hypovolemia, normal thyroid and endocrine functions. This is also important. Second criteria, no correction of serum sodium after intermittent infusion. Suppose you give IV infusion and sodium is still there, that means you may be dealing with SIDH. Second is improvement of hypernatremia after fluid restriction. This is the diagnosis of SIDH. The pathophysiology of this 7-salt syndrome. Surgery, after surgery, there is increased natriuretic factors are there. Like BNP, ANP, OLP, it would lead to increased natriuresis and hypovolemia. And there is sometimes the sympathetic input to the kidney is decreased. There is decreased natriuretic sodium reabsorption and there is decreased renin constipation. That would lead to hypovolemia. And this is the cause of hypovolemia in CHW. This is the cause, right? Okay. So there is increased natriuresis and decreased volume, right? Patient will be having hyponatremia plus hyponatriuresis plus hypovolemia. So in this case, you can differentiate between clinically, you can differentiate whether a patient is having SIDH or CHWS. So coming to take home points now. So hyponatremia is commonly seen after pituitary surgery. It generally occurs in first week of surgery. This is the patient that developed after 1 week of surgery, and usually moderate and patients are usually asymptomatic. However, it will be severe and prolonged in some cases. Different etiologies can explain this hyponatremia. The syndrome of inappropriate secretion, that is SIDH, is one of the most common etiologies. But other differential diagnosis must be ruled out before making a diagnosis. It usually occurs in the first week after surgery and usually moderate and asymptomatic. However, it may be severe in some cases. The management depends on the etiology and must take into account of that acute severe symptomatic hyponatremia, life-threatening emergency. Chronic hyponatremia must be corrected slowly to avoid osmotic syndrome. After having ruled out the intrinsic cause of hyponatremia, then the correction will be done. Water restriction indicated in case of SIDH and slow saline infusion indicated in cerebral salt syndrome. This is the point that I want to discuss with our colleagues. Thank you. So the patient will be fine.
Very good. I think both this case is very important because eyes do not see what mind does not know. It is very common hyponatremia. I think
you did not. What did you give him to take at home? I mean, what medications? Or was he discharged without any medication?
It was discharged without any medicine. You are continuing to
will it be mandatory to call him?
Yes, to monitor. Yes, monitor. Yes, because I take a medicine after we do surgery. Right? Patient might have been should go to hospital. Because there is no specific treatment of this cerebral salt syndrome. You have to correct your. You have to look at sodium to within normal range. Keep the sodium within normal range.
So did you advise him to take more sodium?
Normal diet. Normal diet.
I think Progress and Medicine this year, they have two beautiful articles on hyponatremia.
this year
20.
yeah सर तो आ नहीं आ रहा
तो मैं आपको आर्टिकल लेके आऊँगा बस ये लो मैंने सोचा आप लोगों का
Thank you, sir. Now we'll proceed to our second case. It's a difficult case of GERD successfully managed by a novel endoscopic technique. And the case will be presented by Dr. Naresh Agarwal. He is Associate Director, Department of Gastroenterology, Hepatology and Endoscopy, Rajdhani Clinic. And the case will be chaired by Dr. Rajiv Bansal, past President TDP and Senior Consultant Physician.
I think we all know Dr. Naresh presents very interesting cases. Without wasting any time, I request Dr. Naresh to start his case.
Good afternoon, respected seniors and colleagues. So this is a true short case. I will be spending hardly 10 minutes on this because as I wanted, I could not spend much time on preparation, but I want to introduce one new technique.
I must thank Dr. Naresh also because he is a very short notice.
Yes, sir.
He agreed to present this.
That's the reason that could not spend much time. Anyhow, this is switching from sodium to hydrogen ions.
hydrogen have been troubling us and our patients every now and then, and we find refractory dyspepsia patients, acid, gas, Jalen, and many of them may not have somatoform disorders. Many of them have literal GERD, which is but ultimately those patients who do not respond to our routine therapies in forms of PPI, prokinetics, ultimately we are left with the option of introducing some tranquilizers or sedatives, because the interventional therapies are much more demanding after that. Fundoplication, surgical fundoplication, endoscopic fundoplication, and so on and so on. So we have been doing this technique, which is neither medical nor advanced surgical technique, and gives a tremendous relief for those patients who have mild to moderate refractory dyspepsia not responding to PPI and prokinetics. This is quite short presentation. So this was a 37-year-old male patient. He was diabetic and presented with heartburn, severe retrosternal burning for 3-4 years. We treated him around 2 months back, and at that time this was the history. He had epigastric pain, and according to the criteria,
history.
Sorry?
How long he was diabetic?
He was diabetic for more than 10 years. So it was not tagging with the onset of dyspepsia. So he was categorized as having chronic dyspepsia, and there were no alarm symptoms. So, but he was so distressed with dyspepsia that he was scared of taking medicines, going to doctors, because he was not benefited by anything. There was no loss, no GI bleed. He was also having heaviness because he incidentally had fatty liver. Gross regurgitation in night. He had several bits of spontaneous arousals because of water brush.
Not any alcohol or alcohol?
He was non-alcoholic, non-smoker.
No tobacco.
No tobacco. And gradually he reduced his intake also and developed malnutrition. On examination he was well built. His BMI was around 20-21. BP was normal. He was not having any pallor. So pure symptom which was troubling him was dyspepsia, and for that matter, reflux disease, the most common underlying cause of such problem. Lab reports were almost normal.
He was vegetarian?
Sir, I'm not sure, but he was vegetarian because he was from Brahmin community, so I anticipate that he was a vegetarian. Although I do not remember, but probably
One calculation, did he have any abdominal findings?
Nothing, sir, nothing. Liver was palpable, hardly 2 centimeters. He was having fatty liver because of diabetes. He was not obese. His diabetes was well controlled. So he was having literal dyspepsia, what we read in books according to the group criteria.
He must be on metformin. Drugs, because
Sir,
the anti-diabetic drugs cause a lot of gastric upset, and his metformin and respond even cause pancreatitis.
Sir, one thing which I remember, he was taking Galvus, I think that is Vidavitrin, and
Both.
yeah, he must be taking some something with that also, and some intermittently he was also prescribed with insulin because of late his diabetes was controlled. LFT and KFT were normal. So
10 years diabetic.
yes, more than 10 years.
Exactly, that's what my point.
So we wanted to investigate what was the problem, gastroparesis, because he was not having early satiety or bloating. He was, majority of his problem was heartburn and pain, which is pathognomic of dyspepsia. In gastroparesis, patient will not have prominent pain. So he, as a routine, we started PPIs, and he had a partial response initially, but the tune of response was hardly 20-25%. We increased the dose of PPI, and by that time he developed a lot of anxiety and scared of having, he has some cardiac problem and all. Was referred to a cardiologist. stress echo, TMT were done. They were negative for reversible ischemia, and he was referred back. Then we added some prokinetics, which is the rational next step if patient do not respond to PPIs. But the symptoms were still distressing. There was a partial response to every new therapy, but ultimately was square. And based on prolonged symptoms, because he was refractory, we decided to do an endoscopy. And should be endoscopy. So there was quite interesting findings on endoscopy. Could not edit this video, but so we entered in the esophagus, and here was an interesting finding. So this was the primary cause of his problem. This red mucosa, which is lying above the G junction, is still around 10 centimeters ahead, and there was a gastric mucosa lying in the esophagus, and this was without biopsy. You can label it as Barrett's mucosa. And then we went ahead. There was lax LES. This was not the normal lower esophageal sphincter. On retroflexion, this was duodenum. And on retroflexion, we can see there is a reverted Bell sign, which is suggestive of hiatus hernia. So, nutshell, on endoscopy, patient was having Barrett's, which is the complication of GERD, and hiatus hernia. This hiatus hernia was not very large, but significant hiatus hernia, and in a classification called as Hill's classification, this was classified as grade 2 Hill's hiatus hernia. But after that, patient was very scared of getting any medical intervention and refused to get any therapy, surgical or endoscopic, and in due course of time he also started having dysphagia. Although there was no mechanical obstruction, and this Barrett's can explain, associated esophagitis can explain the difficulty in swallowing, associated with some dysmotility of esophagus, which may be associated with diabetes. We did barium swallow because this barium swallow was done around a month later after endoscopy, which was also not showing any, because Barrett's is a pre-neoplastic condition, there may be development of some complication. He was continued on PPI for 2 to 4 weeks, and again had started having severe symptoms of GA. So the modality which they want to introduce has been in practice for last around at least 5 years, which is called as ARMA. And we did ARMA in this patient. ARMA stands for anti-reflux mucosal ablation, which is an OPD procedure, and it is done using argon plasma machine, in which we have a probe which sprays the heated argon gas on the tissue and can coagulate and avulse that tissue. The depth of the tissue usually does not go beyond mucosa. So the advantage of argon is that it does not penetrate more than mucosa. So likelihood of having complications is very, very low, and this has now picked up as a treatment of choice of such cases, because this does not require surgery, does not require hefty, costly instruments in terms of that STATA procedure, in which we have a suturing device to do fundoplication. So we did ARMA in this patient. How ARMA is done? So this is our endoscope, in which we have retroflexed our tip of endoscope into the fundus, and we can see this area. This is endoscope, and this is the probe of argon plasma. And we touch the mucosa and mark the circumference of lower esophageal junction or sphincter around the endoscope itself, around 1.5 to 2 centimeters away from the scope. So this lies around 2 centimeters away from the G junction, and we mark it like this. So by rotating the scope, we can see the hiatus hernia here. By rotating the scope,
What is there on the tip of the organ?
sir, we have a probe. We can decrease or increase the length of the probe by our hand in the channel of the scope, and there is a pedal. We push the pedal, it will burn the mucosa.
No, I see something white on the tip of the.
That is a tissue, coagulated
Just a
tissue.
tissue.
You are coagulating the.
So we are marking, sir. We are marking the circumference where we have to avulse the mucosa. This is marking. First we do marking, and after that we mark 2 marks in the main radius, in the similar radius around 1 centimeter. So the width of the avulsion is around 1 centimeter, and that inner 1 centimeter is around 1.5 centimeters from the G junction. And like this, we avulse the mucosa, and keep on doing this in the entire circumference, keeping 1 centimeter intact on the greater curvature, because if we avulse the entire circumference, then it can lead to stricture formation. Although that stricture is very soft stricture and can be opened by endoscopy, but to avoid the need of another endoscopy, we leave 1 centimeter in between. This is the greater curvature, this is the greater curvature, and this is the fundus. And likewise, we avulse the mucosa. So it is as comfortable and easy as it seems, because patient requires 5 minutes or 10 minutes of propofol anesthesia. That can be done in endoscopy room, and after keeping around 1 to 2 hours in the hospital, patient can be sent at home, can be discharged. So there is no logical need of admissions, but some TPA patients would prefer to get into the hospitalized conditions.
The length of the Barrett's esophagus was quite significant.
So I am coming to that, because this patient had an added complication of Barrett's. So most of the patients will not have Barrett's. This patient had Barrett's. So after doing this avulsion in the circumference,
Avulsion would mean taking out the mucosa from the submucosa.
sir, this mucosa is
Stripped off.
removed. Yes,
Stripped off.
removed. Before this APC is very easy in performing this procedure. When we do not have APC, there was a practice of incising this mucosa. So we used to elevate the mucosa by submucosal injections, and then with a knife we used to incise this mucosa. That was very tedious and associated with complications, because knife can penetrate into the serosa and foramen. But this APC is wonderful, because it does not, even a beginner will do it so smoothly, because it will not penetrate and not perfect.
Dr. Naresh, on this argument, sir,
What's the scope?
This is the endoscope, sir. This endoscope is going from G junction to the stomach, and the tip is retroflexed. So the endoscope tip is looking at the endoscope itself. So this will guide us where to do the procedure. So this is in the retroflex position. So likewise, up to the depth of submucosa, we avulse this mucosa, and what is the pathophysiology of improvement? That this will form a scar. This will reduce the hiatus hernia, although this is not indicated for Hills more than grade 3 hiatus hernias, because they do not respond as well as grade 2.
थोड़ा सा छोड़ दें greater curvature.
Greater curvature पे 1.5 centimeter छोड़ दें, sir, because there is no yes. This is the left. And this is after the completion of the procedure, and this is the greater curvature.
this is above IGS.
This is below IGS. This is the gastric aspect of GI.
Below IGS. Below.
Yes. In that case, it will form a scar, and G junction will be strengthened because of this mucosal scar. And after that, I don't have video of the next session, in which we avulse the Barrett's mucosa with the APC, similar APC. We elevated the mucosa by submucosal indigo carbon injections that will mark that particular area with a blue color, and very comfortably this APC can be applied at the blue color, and Barrett's mucosa is removed. Later on, that scar forms there. Some patients will form a soft stricture which can be easily without dilatation, with the negotiation of scope that can be dilated, patient is relieved of this case. So after that, the advantage of this procedure is that patient does not require major counseling, major cost. The cost is around 25,000 for one session. Some patient will require a repeat ARMA, and it can be done as a routine procedure. There is no major contraindication, provided patient does not have very large hiatus hernia which do not respond, which requires a surgical operation. So these are the classifications of hiatus hernia, and up to this level we can do ARMA, in which almost 1/3 of the stomach is prolapsing into the esophagus. It does not work. So this patient, the guidelines are that if you want to do ARMA, you have to do a pH metric before that, but now of late there have been recommendations by the pioneers of the field that pH metry is not mandatory. You find endoscopic evidence of esophagitis and symptomatic patient, you can perform ARMA. And just a word about pH, impedance pH meter we have in our department, and that can correlate the patient's symptoms with reflux. Many patients will have reflux symptoms and we do not know whether he is having reflux or not. And we put endoscopy is normal. So we are confused that patient is having reflux or not, and pH metry will give answer to that. And if the average fall in pH is less than 4 at most of the times, this catheter is placed through the nasal route into the esophagus and kept there for at least 24 hours. If not 24 hours, then at least 16 to 18 hours. And just like the Holter machine, we have a recording. And if most of the falls in pH is less than 4 at most of the times, patient symptoms can be related with reflux disease. Reflux symptom association and the longevity of fall in pH can be measured by this pH impedance meter. This machine is same as that of pressure manometry, in which we also diagnose hiatus, achalasia cardia, and motility distress. These are few. And this is a calculated software score, D-Master score. If that is more than 14, that patient is likely to have reflux disease.
We did this esophageal.
Yes, sir. In this patient we did, but now there is no mandatory guidelines to do, as long as there is endoscopic evidence. If there is no endoscopic evidence, then we have to establish reflux. So this was the picture after the procedure. This was the pellets that we used. Don't you?
New mucosa will develop later on or not?
New mucosa
Yes.
will develop, that will be mostly a squamous mucosa.
In what time?
Esophagus, yes sir.
In what time it will develop?
Takes around 3 to 4.
Till then PPI should be there.
PPI is automatic. In this patient, and after a follow-up of 3 weeks, patient symptoms improved markedly. He was still having anxiety, so somatoform symptoms were left. As such, we use some sedatives or some Nexito type of thing in that patient. But reflux-related patient, he was very comfortable. He was very happy also, because otherwise he was saying that I am taken as a functional patient or anxiety patient or depression patient. Most of the places I am not improving. He was having a literal dyspepsia and reflux which was troubling.
What is the immediate post-procedure?
Usually nothing.
Because this is an OPD procedure.
This is an OPD procedure, usually just like an endoscopy. Have some hangover of anesthesia till evening, and some argon gas spills over in the duodenum and jejunum. So he may have bloating for 1 or 2 days because does not get absorbed. So it's better to have a lot of suction at the time of doing procedure, because as much as you should suction at the time of procedure does not go into the eye. Although that remains for 2 days.
What is the dietary advice for the next 2 days, let's say?
Likely just soft diet for 1 to 2 days, and after that. So this is one modality over and above medicines.
End game for this person.
That's what I came to ask.
He is relieved of his dyspepsia.
Would it
likely to
PPI lifelong or
No PPI, sir. We put him on SOS PPI. SOS PPI.
Lifelong.
So it's kind of curative.
Because my personal opinion is that PPI should not be used for prolonged periods.
It's,
Because most of the patient will not require. They are psychologically.
it's kind of curative.
This is a curative therapy.
So
Curative is very easy to do.
Now for we as a physician, what are the indications?
Indications, refractory symptoms, and if patient warrants for an endoscopy and there is an evidence of reflux, not responding to therapy or very prolonged therapy, this even therapy becomes distressing, it can be recommended.
And you didn't do any H. pylori ruling out?
Sir, reflux, H. pylori has a contra association with reflux. If patient has reflux esophagitis, treating H. pylori will not do any good.
All
Dyspepsia,
reflux
in non-erosive dyspepsia, H. pylori eradication helps. Because in that case, H. pylori may be responsible for that. But in erosive dyspepsia or reflux disease, H. pylori has a contra association.
For all reflux patients, this becomes the line of management now?
No, all.
Not all.
Sir, that depends on severity
If it
and
is curative, then why not to be
It is earlier because
You need to delineate the mucosa for the
No,
evaluation.
no, yeah. Because he had
Dr.
Barrett's.
Paras will not leave me, sir. I will, yes, sir.
I'm just curious.
Sir, not all.
All we have so many reflux.
Sir, many patients respond dramatically to short courses of PPI or prophylaxis, and many of them will not have reflux. Short courses of some anti-anxiety medications or treatment of underlying cause like diabetes or hypothyroidism or obesity, morbid obesity. So, treating them is
If the patient is troubling you, or is troubled again and again,
if patient is troubled himself, then but it's better to have a very low threshold for this procedure because this is very safe. Yes, yes.
Now that he doesn't develop it in future, so how often will you be doing upper GI in reports of time?
No
need.
Unless he has recurrent symptoms, which is unlikely.
Two questions.
And how
Because this
will
is
we
a
know
mechanical
about it?
scarring.
Because he's prone to this. He was not obese. He was not having any premonitory predisposing factors. So
So-
how will we know?
So this is a mechanical scarring, and which is likely to persist. So reflux will get treated, although he may be symptomatic because of anxiety or depression or diabetes itself, because he may develop gastroparesis.
I think when you are in sugar, you have actually to do APC in
APC was so this modality has, because before that there was anti-reflux mucosal resection,
and we used to use
ARMR.
used to do it in GAVE.
If it is treatment of choice,
Yeah, treatment of choice.
it's a wonderful technique.
Yeah. So my two questions that example for Paras said every patient should be. I think it's no, because patient would say if it is done, there is no indication. The patient will come to you again, right? You have done this so much procedure and I am not improving. So you have to be very sure that okay, with the patient.
And we get confidence that we have treated his reflux and we have to treat his somatic symptoms predominantly, because otherwise
It is very clear that this is only for patients who have very chronic dyspepsia, water rash, and patient is discomforted, and all other investigations are normal. Then I think we should.
and to put him off PPI, because PPI, how long he can take
I think
PPI?
a question which is not related. Yeah, I think it's important observation that if you can do it, you could see that there is esophagitis, there is symptoms of reflux. So manometry may or not, because sometimes in this procedure, sometimes you would require a manometry.
Yes.
Manometry in every case before the procedure.
pH medication. Yes, yes, yes. If no endoscopic evidence,
pH measurement doesn't need endoscopy. You just
no, does not need
you just
endoscopy.
put in a
It
catheter.
has a transnasal catheter.
Transnasal catheter.
So sometimes what is the
That
cause?
catheter is around 12 French.
What is the cause of the procedure? For the patient, accident patient. Cost.
Cost 25.
All inclusive.
All inclusive, including anesthesia.
No need cost.
Including anesthesia.
Off this topic, most of our patients are on chronic PPIs.
Yeah.
So, what is your view on that? Because I personally don't want to keep, because it causes total gastric acid suppression, which is not
Sir,
at all desirable.
chronic PPI is not needed medically. This is truth. patient is taking, doctor is giving
When we try to tell the patient कि don't take this, तो इससे किसी एक दिन भी नहीं जाता है problem है.
that is the evidence that he is dependent psychologically, and doctors also become psychologically dependent for patient to give him
So what I tell them, then you take it alternate day or you
As
put it
well.
off,
as
so
well as
that some acid suggestion is there.
Yes, sir.
But there used to be times when it was defined as a chronic illness that you need to be on long-term PPI, like you are on anti-hypertensive medication or anti-diabetic.
So
There has been
logically
data
there is
of
no
10
medical.
years consecutive usage on that. So what is that actually?
So that is not sir, medically or logically correct, because there is no medical indication to give prolonged PPIs for
What are
more
your
than
current
5 years
guidelines?
or
What
10
are
years.
your current guidelines about PPI?
No guideline to say to dictate use of PPIs for 5 to 10 years. And this is not permitted in Europe and America. They are large.
How do they define? 6 weeks, 8 weeks, and then you lower it down, and then how?
That depends on indication. For example, if it is H. pylori, then you give it around for 1 month. PPI for 1 month and antibiotics for 14 days.
हिंदुस्तान की गैस तो खत्म ही नहीं होती, डॉक्टर साहब क्या करें?
अगर कोई पेशेंट एस्प्रिन ले रहा है, उसमें भी सर नाउ देयर आर वेनोप्राजान आ गई है, इंडिया में नहीं आई है, बिकॉज दैट इज लाइकली टू हैव लेसर renal and osteoporotic side effects. So that is now drug of choice in US.
Which one?
Venoprazan.
Reno?
Venoprazan. That is a proton pump inhibitor that acts at different level. It's a preformed drug because PPIs are sulfonamides and they are converted into active component in the parenteral cell. So they are preformed and they have lesser side effects in comparison to PPIs in terms of renal side effects, osteoporosis, pathological fractures.
Which is the safest PPI for kidney?
So most of the studies are with omeprazole and esomeprazole overseas, but no comparison. Everyone will have.
Are H2 blockers better than PPIs?
H2 blockers efficacy means efficacy is hardly 2/3 of PPIs
They're effective then.
with maximum dose.
Yeah.
So what is the role of prokinetics?
Prokinetics that depends on dysmotility. If there is dysmotility or gastroparesis like of thing, then they will help. Otherwise, they are just like placebo.
Don't they activate reflux?
Symptoms are symptoms, and if there are chronic symptoms, we can investigate by manometry, or there are scintigraphy tests for gastroparesis and a background disease patient. will-
Reflux diseases after taking domperidone?
Sir, motility of esophagus, ejection, stomach will increase. But if they are defaulted, then they will benefit. Otherwise, they will act as placebo.
And what effect
So
do they
there are
have on
different
LDS?
indications for use of prokinetics.
And what effect prokinetics have on LDS?
LES, etopride, levosulfuride will work better. The domperidone is more of.
Sir, how many cases of extra pyramidal symptoms we have seen with levosulfuride?
Levosulfuride, madam, I have not seen much because.
Because I have seen few cases, and they have reverted back to normal after stopping levosulfuride.
I've seen some instances of sedation. Although I'm not
That's at the central level also. It interferes with the.
It was introduced as a central drug.
Apart from the drugs and the therapeutic interventions like endoscopy, you must be advising them about the lifestyle.
Yes, sir, very
I'm
important
telling you,
issue, very important
I
issue.
had for 3-4 months myself. I had a severe reflux.
Very important.
I consulted Rajesh Upadhyay, D.K. Bhargav. They all gave me this. Ultimately, I went to Dr. S.P. Kalu. I just discussed it. He said, चतुर्वेदी साहब, आपको डायबिटीज है, आप फेमस वगैरह लेते हो, आप रात को सोने से पहले there has to be a gap of 3 hours.
Yes.
And आधा गिलास ठंडा दूध लेके लेफ्ट साइड कटोर पे लेट जाओ. Believe me, भाई साहब, 3 महीने होते हैं, उसके बाद से कोई प्रॉब्लम नहीं. तो ये लाइफस्टाइल मॉडिफिकेशन हमारी ओल्ड ट्रेडिशनल
After the age of 40 years, lifestyle modification will have major positive impact on response.
Actually, most of the doctors have their meals in the night, and we should not eat anything after 7.
Exactly.
If you don't have reflex
7 बजे तो
if you don't have reflex symptoms, you can eat it.
I think.
Say like that because
Thank you very much, Dr. Naresh.
Thank you, sir.
Excellent
most of the
session.
people know.
Very interesting and very informative. Thank you.
Yeah,
हाँ तो पहले
World Health Day.
चीफ ऑफिसर आपकी उस डिपार्टमेंट में नहीं उससे पहले क्या आपको लोगों को लेकर के आना है उनकी वेलबींग के लिए आपको कॉन्फ्रेंस Charity begins from home.